afternoon, everyone. Hope everyone had a nice Thanksgiving. Welcome to our weekly endocrine grand rounds. We are very happy to have one of our own faculty, Malika Rawal, to talk to us today. She joined us in 2019, just before the pandemic, and has been with us as a fellow and now as faculty, and has been interested in general endocrinology with special interests in transgender medicine. And she today will present to us on the topic of normocalcemic primary hyperparathyroidism, an interesting and increasingly recognized area. So, Malika.
Thank you, Dr. Mukshagandam. Thank you, guys. It's been a while since I've heard a in-person clap, so thank you. Good start. So today I'm going to talk about this subject and was recommended and suggested by Dr. Krishnasamy, so I hope to do it justice. And I know it's something that we all struggle with diagnosing, and spoiler alert, by the end of this, you're going to realize a lot of people have the same struggle. So we're going to talk about how we can refine the diagnosis and what this actually really means for our patients, and how we should advise them. So we'll get started. So I have no conflicts of interest related to today's talk. So here are some general objectives and kind of a framework for how I'll discuss this topic. So I want to first talk about the definition of normocalcemic primary hyperparathyroidism, talk a little bit about what we know about its history, and what we can expect to see. We'll talk a little bit about the physiology of vitamin D, parathyroid hormone, and calcium, and review how we make these diagnoses. We'll talk about what this means for our patients. So if they have normocalcemic hyperparathyroidism, how does that affect their health and their overall lives? And then talk about what we know about management. And again, I have a tendency to pick topics that don't have a lot of clear information, but we'll try to do our best. So first of all, what is this condition? So we're going to see a lot of acronyms today. I'm going to try to make them clear and try to not abbreviate too much, but the main topic today is normocalcemic primary hyperparathyroidism. If you break that apart, this is hyperparathyroidism coming directly from the parathyroid glands, therefore primary, but the calcium remains normal. And it's abbreviated as NPHPT. So this entity was formally recognized back in 2008 at the Third International Workshop about the management of asymptomatic hyperparathyroidism, and they refined it about 6 years later at the 2014 workshop. And really this workshop talked more about our typical hypercalcemic primary hyperparathyroidism that we're used to seeing in patients and diagnosing, but did recognize normocalcemic patients as their own entity and try to lay down some ground rules of how we can manage them and monitor them. So the definition is elevated parathyroid hormone level in the setting of a normal total serum corrected calcium. Both of these should be measured at least twice, so PTH and calcium both, and they should be 3 to 6 months apart, and still maintain this definition to fit normocalcemic hyperparathyroidism. And this is where we're going to see a lot of the issue, because a lot of the studies that talk about the prevalence or the complication rate in normocalcemic hyperparathyroidism don't stick to this strict definition. And part of it is because we don't fully understand the course of the disease. We know that their calcium levels may be normal initially, but we don't know if it's natural for them to become hypercalcemic. Does that then make them no longer NPHPT, but hypercalcemic primary hyperparathyroidism? So, we're going to try to keep this definition in mind and see if we can apply it to the studies that I'm going to present. When there is a secondary cause for the parathyroid hormone elevation, we call that normocalcemic secondary hyperparathyroidism. And when there is not a known secondary cause for PTH elevation, then it is normocalcemic primary hyperparathyroidism. And that is the subject of today's talk. Just a reminder to everyone of how we check a total serum corrected calcium. We take their total serum calcium and add 0.8 times 4 minus their serum albumin level. and that gives us the albumin-corrected calcium. And so that's kind of important to keep in mind as well, because we always have to take into account changes in our albumin level when looking at the calcium level overall. So normocalcemic primary hyperparathyroidism can be in the literature due to either a single adenomatous gland, multiple adenomatous glands, or multiple gland hyperplasia, just like classical hypercalcemic primary hyperparathyroidism. And this has been documented in several studies, some of which I've listed there. There's also in literature an increased incidence if there's a history of radiation to the neck or cervical region, again, similar to a classical hyperparathyroidism. There seems to be a female to male predominance, but I think this isn't clear in most of the studies because of recruitment bias and things of that nature. So in general, I think it, again, follows the same kind of gender predilection as classical primary hyperparathyroidism. Some of the diagnostic challenges. So we know that this is an entity that we're trying to more frequently recognize or diagnose, and it's being found more often because we're doing more evaluation for bone disease, osteoporosis, osteopenia, metabolic bone disease, and for that reason, more people are checking PTH levels and calcium levels. Otherwise, in a patient with a normal serum calcium, there are not many instances where we need to measure a PTH otherwise, unless we're looking for stones or bone disease. Another challenge is that there's not a good consensus prior to this fourth workshop of asymptomatic hyperparathyroidism on what a normal vitamin D level is. And that's not just within our own country, but internationally. So some people say 20 nanograms per milliliter is the cutoff. Some people say 30. We know that parathyroid hormone can start to elevate anytime your vitamin D level falls below 30, but how much and how clinically significant is it? So looking at the different studies that describe normocalcemic hyperparathyroidism, we have to keep in mind the cutoffs that they use and how that might affect their PTH levels. The fourth workshop, the international guidelines recommend a vitamin D level over 30. So that's what we'll kind of look for and hope for in the studies that we really pay attention to. Another thing is that, there's varying accuracy of the PTH assays themselves and availability of checking PTH in some smaller centers. So the recommendation is to use a second or third generation PTH assay for increased reliability and accuracy of measurement. Um, Also, what is a normal PTH? So just like most lab values, the normal range of PTH follows a Gaussian curve. So there are people whose PTH level falls outside that 95%, but for them, that might be a normal level and maybe their physiology. So that's also another part that we have to keep in mind. We also don't do a great job of always screening or asking about dietary calcium intake. So we know as dietary calcium intake increases, PTH may therefore go down, and we may unmask some other kinds of conditions or secondary hyperparathyroidism. We know that in premenopausal women and men, we recommend 1,000 milligrams of calcium a day. And in elderly individuals, we recommend 1,200 milligrams of calcium a day, particularly postmenopausal women. So in studies, we're going to look for if they screened for that and how that affected their PTH levels. This is particularly important because one of the biggest confounders and biggest differentials in diagnosing normocalcemic primary hyperparathyroidism is secondary hyperparathyroidism. So we have to be on the lookout for any reason why their calcium might be considered normal with an elevated PTH. Another challenge is figuring out what a normal calcium level really is. So just because we have a range doesn't mean that there can't be a trend in a patient's calcium level that actually might indicate an underlying problem, such as primary hyperparathyroidism or hypercalcemic primary hyperparathyroidism. For example, a patient whose PTH level is always over 65 or the upper limit of normal, or close to the upper limit of normal on most assays, and they have vitamin D levels above 30, say their baseline serum calcium is 8.9, which is in the normal range on most assays. And then later, 3 to 6 months later, it's 9.6, and then it's 9.9. These are all normal values, but there's definitely a trend. So we have to keep in mind the overall pattern. Technically, this person would still have normocalcemic primary hyperparathyroidism, but the next challenging part becomes how accurate is the total serum albumin corrected calcium. So a lot of times what they found in studies that I was reading is that when you check the ionized calcium, actually the ionized calcium is high, even if the albumin corrected calcium is normal. So then would you then call this person a hypercalcemic primary hyperparathyroidism rather than normocalcemic? So there is yet to be consensus on the nomenclature and when we kind of reclassify people. What that actually means clinically for a patient, it it doesn't make a huge difference in the management. We would still do the same kind of things, but it's kind of one of those classification things. So when to reclassify them as primary hyperparathyroidism, that is the classical form. So why should we be so concerned about the diagnosis and when is it what? So in some studies, it's estimated that 30% or more of patients that are normocalcemic and have primary hyperparathyroidism will progress to symptomatic disease. And they can have the same end organ damage, such as osteopenia, osteoporosis, nephrolithiasis, AKI, and renal insufficiency, as patients that are hypercalcemic. So even if their calcium remains normal and they never transition to classical, they still can have the same end organ damage. And that actually plays a big role in their health and their overall lifespan and their morbidity. So that's why we're going to try to find out more about this over the next few slides. So figuring out the incidence and prevalence, again, is similarly challenging. So I found one retrospective study done over the course of 5 years that was held in the United Kingdom. And this researcher and his colleagues were trying to figure out how often normocalcemic primary hyperparathyroidism actually occurs. So they enrolled 6,280 patients over this period. And of that, only 11 patients fit the criteria or their criteria for normocalcemic primary hyperparathyroidism. And that was a prevalence of about 0.18%, so less than 1% in their study. However, their vitamin D cutoff was 25 nanograms per milliliter, not significantly different from 30, but not the strict criteria that we use in our international workshop consensus. And they also did mention that of the 11 patients that fit their criteria, only 7 of them remained normocalcemic consistently throughout the study, and only of the 7 that remained normocalcemic, only 2 of them continued to have elevated PTH. Other ones ended up having a normal PTH eventually, which could represent a secondary hyperparathyroidism that was corrected in some way during the study. So again, very difficult to kind of use this as a clear indication of the incidence or prevalence. Oh, I apologize. I said 7 out of 11 patients remained normocalcemic, but it was actually only 4. So the question becomes, those 7 patients that did not remain normocalcemic, would we then reclassify them as classical primary hyperparathyroidism? In their study, they didn't. So they still called them normocalcemic because it was just intermittent hypercalcemia. It wasn't progressive increase in calcium. Another small study that was done in southern Italy was trying to figure out the incidence. And the reason I selected the smaller study is just to kind of show again that there needs to be more studies with more stringent attention to the criteria. So in this study that they looked at, they were trying to calculate the incidence of normocalcemic and hypercalcemic primary hyperparathyroidism. They identified 3 males in their small village that had normocalcemic hyperparathyroidism, and 4 females that had primary classical hyperparathyroidism with high calcium. And the conclusions they drew were that normocalcemic patients tended to be younger in age, 47 versus 66. They tended to have a lower BMI. But look at the variability of the calcium intake. So very variable. And this person only had 107 milligrams of calcium per day. so very minimal calcium intake. Interestingly, though, their PTH levels did not differ that significantly. So I kind of found that interesting because I would expect this patient to have a little bit more PTH elevation possibly. But their albumin corrected calcium remained in the low end of normal range, so normocalcemic, and their vitamin D levels were above that cutoff of 30. So these people did truly fit the criteria. However, over the course of the study, when they continued to follow them, 2 of them had periods of hypercalcemia. So does this represent a progression of disease, or does this mean that maybe they didn't classify it correctly? If they had measured an ionized calcium, would the ionized calcium have been high or normal? So still unclear. All right, so let's go back to physiology a little bit to remind ourselves how all of these things fit together. So our parathyroid glands, and most of us are 4 in number, but a small percentage of the population may have 2, 3, or 5 glands, and they may be ectopic in about 15%. So they're located posteriorly to the surface of the thyroid gland. This is a posterior view of structures in the neck, and you can see the thyroid gland here, anterior to the trachea, and our 4 small parathyroid glands in this patient on the posterior surface there. And parathyroid hormone, as we know, is a very important and key player in calcium homeostasis. Parathyroid hormone is going to directly stimulate calcium release or increase serum calcium by releasing from bony matrix and increasing calcium reabsorption in the kidney. And it's indirectly going to increase serum calcium by activating vitamin D to increase gut absorption of calcium. So, keeping all these things in mind, when vitamin D is low, parathyroid hormone will increase to help to maintain a normal calcium level as well. And that's what we call secondary hyperparathyroidism. So all these things play a role together. So how is it that we think normocalcemic primary hyperparathyroidism works? So there's a couple theories on what we think it is. The most common theory is that this is actually a precursor of classical hypercalcemic primary hyperparathyroidism. So Rawal and colleagues in 1980 first described this theory, and they said that there's a biphasic progression of the classical primary hyperparathyroidism as we know it. Initially, parathyroid levels start to elevate because of PTH resistance, but calcium is still within the normal range. At some point, the classical phase takes over, and that PTH elevation is enough to now cause a serum calcium elevation above the normal range. The problem with this is that not every patient that is diagnosed with normocalcemic primary hyperparathyroidism becomes hypercalcemic. So then how do we explain that? If this is a progressive disease, how do we explain that some patients never develop hypercalcemia? Does that mean that those patients actually might have had a secondary hyperparathyroidism and were misdiagnosed? Or do some normocalcemic patients truly history? Another theory is that in women in particular, and if we remember that they felt like there was a female predominance of this condition, that there's a secondary hyperparathyroidism of aging and also related to estrogen. So in a study in 1994, this researcher Ledger and his colleagues were comparing elderly women, a mean age of 73, to younger premenopausal women whose mean age was about 30. And they basically saw that in the elderly women, their baseline PTH values tended to be higher, without stating if they were outside of the normal range, but tended to be higher in general. And whenever they tried to perform EDTA-induced hypocalcemia, the elderly women had a greater sensitivity of PTH response, meaning they had more exaggerated PTH response to that EDTA-induced hypocalcemia. They also were able to reverse this phenomenon by giving them calcitriol treatment, so suggesting a secondary pathology there as well. And so their theory is that even though this might have been some kind of secondary hyperparathyroidism in this case, they said that in general, when there is decreased estrogen, there's decreased suppression of baseline parathyroid hormone. So levels tend to be higher. And that might also because if there's any parathyroid hyperplasia, which there may be parathyroid hyperplasia, multiple glands in normocalcemic hyperparathyroidism, and that might explain why their PTH levels are higher. In a similar study in the same year, another researcher looked at a cohort of postmenopausal women with osteoporosis, and we're comparing women that were on estrogen hormone replacement therapy versus those that were not. And they found that the subjects that were on estrogen had lower baseline PTH levels. So just like we saw in the other study, those with estrogen had lower baseline PTH. And subjects that received estrogen had a blunted PTH response to EDTA-induced hypocalcemia. So in conjunction and fitting with the prior study. So there's some role of estrogen in our PTH response that may contribute to increased levels of PTH in postmenopausal women and increased incidence or diagnosis of normocalcemic hyperparathyroidism in that population. Yes. That I'm not sure. I don't believe so. Well, you know what? I take that back. I can't say with certainty, but the way that they found it is that we started recognizing this condition because of patients who had osteoporosis. And the people that we diagnose usually tend to be of an older age. So I would say even if that wasn't recognized at that time, there may have been an association.
Okay, so like
Correct. But if we looked at that small Italian study, which again, I don't know that we can draw many conclusions because it was such a small study, those patients that were normocalcemic tended to be much younger than our typical primary hyperparathyroid patients. Rather than a mean age in the 50s and 60s, as with classical hyperparathyroidism, their mean age was in the 30s. So it's still not completely clear what exactly is triggering it and age-wise. I think, though, we tend to look in patients that are of older age, and we may be missing a whole couple decades of patients that have this at a younger age. So could be possible. Okay, so another thing that's been looked into regarding the cause of this condition is if there's any genetic component to it. So a group were investigating a single nucleotide polymorphism in the calcium sensing receptor, and they wanted to see if there was any difference in those that had the A allele, which is the wild type, versus the S allele. And so they recruited 38 patients in this study. Of them, 24 had, in their eyes, had met the definition of normocalcemic primary hyperparathyroidism, and 17 of those 24 patients were carriers of the S allele. So they felt like that S allele was responsible for higher levels of intact PTH, and made an association there. But not sure if clinically this is going to make a difference in us as everyday practitioners, and if it's feasible to do this kind of genetic study to kind of make a diagnosis one way or the other. All right, so how do we diagnose it actually? That's the main thing. So it's recommended to do a set of baseline labs similar to that you would do of hypercalcemic hyperparathyroidism. So of course, to get an ionized calcium if available, but really total serum calcium and albumin could be sufficient, and in some studies are actually preferred. We want to check our phosphorus, alkaline phosphatase, a PTH, remembering to use a second or third generation if possible. Check 25-hydroxy vitamin D, magnesium, and do a 24-hour urine calcium and creatinine. It's also recommended to do a stone risk profile. Of course, check their GFR and evaluate liver enzymes to rule out any secondary causes of PTH elevation. Other studies that are recommended in that 4th International Workshop for Hyperparathyroidism include bone mineral density at the lumbar, spine, hip, and distal third radius, just like we would with our classical hyperparathyroid patients, to do a VFA to evaluate for any fragility fractures that might be missed by the DEXA, and to do consider optionally in a center where you have it available to do high-res CT a trabecular bone score, bone turnover markers, and a fractional excretion of calcium on a timed urine sample. But definitely not necessary. Interestingly, they do make a tip in multiple studies that if the person is hypercalciuric, to consider to do a low-dose thiazide challenge in those patients, because this might actually unmask hypercalcemia and reclassify them from normocalcemic hyperparathyroidism to primary hyperparathyroidism, the classical type with hypercalcemia. And most importantly, cannot stress enough is to rule out all secondary causes of PTH elevation. So this is a very extensive list and reminds us of all the different things that can contribute to PTH elevation, and possibly changes in our serum calcium from their true baseline. So this includes CKD, and theoretically, patients should have a GFR greater than 60 to fit the criteria for normocalcemic hyperparathyroidism, excuse me. Any malabsorptive syndrome, so if they've had bariatric surgery, they have short gut syndrome, celiac disease, IBD, or have a history of gastrectomy. Those patients that have nephrolithiasis due to idiopathic hypercalciuria, of course, vitamin D insufficiency and deficiency, Paget's disease, FGF 23 mediated disorders, in which case we would note a very markedly low phosphorus. So that's the key in ruling that out. And then a number of medications, including, of course, denosumab bisphosphonates that are used for osteoporosis, and in the patients that sometimes are suspected of having normocalcemic hyperparathyroidism, lithium, SGLT2s in our diabetic patients, and calcium channel blockers, and other such meds. All right. Oh, got stuck. There we go. Another possible test you can do, or rather a calculation you can do to figure out if this might be normocalcemic hyperparathyroidism, is something called the calcium phosphate ratio. And so really this has the best use in confirming classical hyperparathyroidism or normocalcemic hyperparathyroidism. And they use the albumin-adjusted serum calcium level and phosphorus, so things that were part of our initial workup anyways, and readily available to us. So in a study in 2018, Medeo and colleagues proposed a cutoff calcium phosphorus ratio of 3.5. And using this, they said that their sensitivity was 89%, specificity was 91% for detecting either classical or normocalcemic. But the positive predictive value for normocalcemia was 73%, and the negative predictive value was 88%. In the distractors from it, or the detractors rather, sorry, was that it's a single calcium measurement. You're doing one moment in time. Whereas the theme of today has been that normocalcemic hyperparathyroidism is a continuous condition where normocalcemia should persist over a period of 3 to 6 months or longer. So may be less useful just on one measurement. When a lower cutoff was used, the sensitivity did not change significantly, but the negative predictive value did go up. So if anything, the calcium phosphate ratio might be something that's useful to ruling out normocalcemic primary hyperparathyroidism rather than ruling it in. So something to keep in mind. And if you were to rule it out, then you would start looking for more secondary causes and kind of be more exhaustive in your search for other reasons of PTH elevation in the setting of normal calcium. Another calculation we can use to maybe lean towards a diagnosis of normocalcemic hyperparathyroidism is the PF index. And this is really used to distinguish primary hyperparathyroidism from secondary due to vitamin D deficiency. And they use the calcium multiplied by the parathyroid over phosphorus ratio. And these are the units that they suggest using when doing this calculation. So different calcium units than we typically use. And then in a study where they used this PF index, they looked at 128 patients and they had surgically confirmed primary hyperparathyroidism. 36 of them were normocalcemic at the time of their surgery. So again, not clear on that diagnosis, but they considered them normocalcemic primary hyperparathyroidism. And if you use the PF index over 34, you can discriminate normocalcemic primary hyperparathyroidism from secondary hyperparathyroidism with a sensitivity of almost 97%, specificity of almost 98%. But again, this is a calculation based on a point in time, and single values. And we know that the course of the disease may change. Even with primary hyperparathyroidism, where there is hypercalcemia, they have intermittent periods of normal calcemia. So, it's hard to catch a diagnosis just based on one moment in time. So say someone does have normocalcemic primary hyperparathyroidism, and we make the diagnosis with confidence. What does that actually mean for our patients? Versus if we're not able to make the diagnosis with confidence, we don't know if this is hypercalcemic, that is in a quieter state, is this normocalcemic? What does that mean for our patient? So in the studies that I reviewed, patients with normocalcemic primary hyperparathyroidism compared to classical hyperparathyroidism tended to have lower bone turnover markers, but still higher than the general population. They tended to have lower net calcium release, so their calcium to creatinine ratio was lower. They tended to have similar elevations in PTH, so it's not that hypercalcemic hyperparathyroidism has PTH levels significantly higher, and you can use that to distinguish. So they tended to be very similar, especially in the study that I cited there. Patients that were normocalcemic had decreased ability to suppress phosphorus reabsorption and to promote calcium reabsorption, thus explaining why they had higher phosphorus levels and lower calcium levels than the hypercalcemic patients. And in general, whenever their glands were investigated surgically, if they had a parathyroidectomy or in postmortem studies, the glands tended to be hyperplastic, but tended to have lower weight and smaller size than those with classical hyperparathyroidism. So, just something to consider. So all of this evidence kind of points towards that theory that this is a progression. This is the initial phase that we're catching it in, and it will progress at some point. When is the question? All right. As far as bone complications, on the first slide, I talked about how, normocalcemic hyperparathyroidism can still have end organ damage regardless of hypercalcemia. In going through studies further, what I found is that the complication rates tend to be very overreported because most of the studies are done from referral centers for osteoporosis and metabolic bone disease. So there's definitely a bias in who we're looking at. I don't know that there's a way to change this per se because this entity is studied in patients that have these complications. So keeping that in mind, this group here, Charopoulos and colleagues, looked at postmenopausal women with either classical or normocalcemic hyperparathyroidism, and they did quantitative CT scans of their tibia. And what they found is that patients with normocalcemic primary hyperparathyroidism still had catabolic findings in both cortical and trabecular compartments of bone, just like in classical primary hyperparathyroidism. And they had deterioration more in the cortical geometry than the trabecular architecture, so more effect on the cortical part of bone, which is a little different than, primary hypercalcemic hyperparathyroidism. But the drawback is that this study was a very small study and they had a small sample size. So I'm not sure what conclusions we can truly draw from it. As far as kidney stones, and we'll come back to bone a little bit more later, but as far as kidney stones, in patients with normocalcemic hyperparathyroidism, and it's hard to know if really there is an increased incidence or if it just happens that we check PTH in patients that have kidney stones, and that's why we see an association. So in the general population, the incidence of nephrolithiasis is about 10-11%, and the claims of incidence of nephrolithiasis on studies of normocalcemic hyperparathyroidism patients range from 3 to 30%, so spanning both sides of that. And I'll show you a table of a meta-analysis kind of talking about these complications in more detail. What has been documented in multiple studies, though, is that there's a lack of improvement of nephrolithiasis after having parathyroidectomy for normocalcemic parathyroidism, hyperparathyroidism. And one theory for this is that, it's more common to have multi-gland disease. So depending on the type of surgery that's being done, whether they're doing removal of one gland or they're doing 3.5 glands, may or may not see improvement in that. So there has to be more detail in studies about what exactly was done and more control over we're doing this kind of study versus this kind of surgery versus this kind of surgery, and these are the results between groups. So there hasn't been anything like that. Everything has been very retrospective rather than case controlled or randomized in that manner. How often does this progress to classical? Again, this is supposed to be an initial phase of classical hyperparathyroidism, but how often have we proven that it actually progresses? So one study that I found looked at a predominantly female population that they had called as having normocalcemic primary hyperparathyroidism, and they saw only 25 of them convert to frank hypercalcemia within a 6-year period, which is a 18% progression. 42% of these patients did have reduced bone density, but they didn't mention in the study whether they had osteopenia or osteoporosis, but they developed reduced bone density over this 6-year time period. The question here becomes, is this a feasible time period to expect these things to happen? So if we had a longer period of observation, would we have seen more? So something to keep in mind. In the larger study by Sheeny and colleagues, they had very variable rates, anywhere from 0% in some studies, because this was a meta-analysis, to 19% in some studies. But they commented at the end that if they actually applied the international workshop rules, the incidence would have been 0%. So none of them would have progressed. So we're kind of still left not sure of how this is going to go. So here's a summary from a meta-analysis trying to look at the incidence of skeletal and renal complications from primary hyperparathyroidism. And most of these studies solely looked at normocalcemic patients, but some included also hypercalcemic classical patients. So you can see here in this first study in 2003 that about 18% of the patients had some kind of demineralization or decrease in bone mineral density without really saying this is osteopenia, osteoporosis. And more than a third of them had kidney stones. Again, was this causal or was this just related, right? So unclear. In this study, osteoporosis incidence was much higher than the previous study, 36%, and only 9% had kidney stones. And this trend continues throughout these studies. So not a really clear incidence of either complication. And it seems to be more coincidental at this point than causal. So how do we manage them? So medical management in general tends to focus on the comorbidities that tend to be there. So patients that have osteopenia and osteoporosis receive treatment accordingly. The only medication that's been studied in normocalcemic patients specifically is alendronate. Either one group got alendronate and cholecalciferol, one group only got cholecalciferol, and they evaluated their bone mineral densities over several years, and they did show improvement in bone mineral density with alendronate without significant effect on their serum calcium levels. So again, emphasizing that we should still treat the complications or the comorbidities rather, and optimize their vitamin D level always, because we're always worried about misclassifying a secondary hyperparathyroidism as normocalcemic primary hyperparathyroidism. So shooting for that vitamin D level above 30 whenever possible. There were some studies talking about the use of cinacalcet, specifically not because we want to normalize calcium levels, because they're supposed to be normocalcemic anyways, but maybe they would have some effect on the comorbidities. None of the studies showed improvement in bone mineral density or decreased fracture incidence when using cinacalcet in these patients, but there were 2 studies that talked about possibly decrease in size and number of kidney stones using cinacalcet. So that could be a consideration. Again, this is not a guideline. It's not recommended in that way, but just an observation. And then, of course, if we are suspecting that it might progress and we think this is a progressive condition, then we should continue to serially monitor their calcium levels and make them very well aware of symptoms of hypercalcemia to be on the lookout for and to let us know of so we can reevaluate them sooner or at least every 3 to 6 months. Operative management is a very interesting area. So again, these patients in general, they tend to have multi-gland hyperplasia rather than single adenoma or multi-gland adenoma, but all of these are possible. In general, when they do find it, the gland is smaller than in classical hyperparathyroidism. So what does this mean for surgery? It means that really there might be a lower cure rate, and then also that it may necessitate bilateral neck exploration rather than minimally invasive techniques. So something to keep in mind from surgical planning. Um, there's a greater risk for postoperative hypocalcemia because they're normocalcemic to begin with. Um, you know, preoperative planning, as far as imaging, can be difficult because sesame scan and the studies that have looked at this can be positive in only up to 42% versus 81% in classical cases. And even we've all had our classical hyperparathyroid cases where they couldn't identify anything on imaging and they had to identify everything at the time of surgery and do and opt not for the minimally invasive surgery. There's still a role whenever we operate on these patients to do intraoperative PTH monitoring and calcium measurement, of course. And some studies cite a cure of normocalcemic hyperparathyroidism by trending the PTH levels. We'll look at those on the next slide. However, in multiple studies that I read, it's still a common finding for PTH to remain elevated even after parathyroidectomy, even after 3.5 gland removal, which again tells us there may be some secondary etiology for the PTH elevation that we're missing, whether it's dietary calcium intake or a medication or anything of that nature. Some studies have said that there might be improvement in lumbar spine BMD scores after parathyroidectomy, but most of them did not show any improvement in BMD scores after parathyroidectomy. So unlike our classical patients, it's not going to have a significant impact on their bone health from what it seems. So here's one study talking about surgical management of normocalcemic primary hyperparathyroidism. And so they did a retrospective chart review of patients at a single institute, and they were looking at patients that had what they call sporadic primary hyperparathyroidism, which basically means they had normocalcemia, and they had parathyroidectomy. And basically, they said that most patients that have apparent normocalcemic hyperparathyroidism actually had elevated ionized calcium levels. So again, a question of classification, would we call this classical hyperparathyroidism then? Or would we just use the albumin-corrected calcium as our only calcium level that we're considering? And whenever you do have patients that are undergoing parathyroidectomy, you should still monitor ionized calcium and intraoperative PTH to guide a successful operation, as they say, so to look for that drop in PTH, which may not be persistent. Another study, which was a case series with chart review, was looking at patients that were considered to have normocalcemic primary hyperparathyroidism. And they, again, did not specify that they had multiple measurements, but they said they had normal range calcium and serum elevated parathyroid at least once at the same time. So they concluded that surgeons that are treating these patients should always consider multi-gland disease, and that kind of led to the recommendation to consider bilateral exploration rather than just minimally invasive techniques in these patients that are normocalcemic to have the best results. These are the guidelines from the fourth consensus workshop, and these talk more about asymptomatic primary hyperparathyroidism, which includes hypercalcemic and normocalcemic patients. And basically, they're saying that these are indications for surgery and how they changed over time. So most recently, our recommendations should seem very familiar, but anyone with hypercalcemia more than 1 milligram per deciliter over the limit of normal. So this is the classical patient. Any patient that has a BMD or a T-score of more negative than 2.5 or osteoporosis definition at any of these sites. Anyone that's had a vertebral fracture, those are patients that should be considered for surgery. So whether they're normocalcemic or hypercalcemic. Anyone with a creatinine clearance that is less than 60, or they have hypercalciuria, or they have increased stone risk by biochemical analysis, should be considered for surgery as well still. And then the presence of nephrolithiasis or nephrocalcinosis on imaging also is an indication for surgery, and their age should ultimately be less than 50. So these are the guidelines that we have to follow to say who might be a good surgical candidate. These are the recommendations of how to monitor normocalcemic patients. So checking calcium and PTH annually and doing a DEXA at the same interval you would for a patient that was hypercalcemic. If they do progress to hypercalcemia, follow the guidelines appropriately on when to refer for surgery, when to start medication. But if they have progression of disease and they have any end organ damage, regardless of their calcium, you should recommend them for surgery is what they're recommending. And it's Dr. Belzikian, so we have to believe him. He's the boss. So that's what he says. All right. So this is how often they recommend that we monitor our patients who do not undergo surgery. And they recommend that we check calcium annually. We do skeletal evaluation every 1 to 2 years at 3 different sites. And we annually do this stone analysis, GFR, and 24-hour urine collection. This is a very busy algorithm, and I just included it because I think it perfectly summarizes how I felt preparing for this, and that it's a lot of confusion and really not a lot of guidance. But this is from an article that is trying to guide us on what to do with patients that have persistently elevated PTH and normal corrected calcium and normal ionized calcium and no known secondary factors. So first, make sure our PTH assay is adequate. So did we use a good PTH assay? Is it persistently elevated? If it is, then we need to, again, rule out any secondary causes. So we're going to look at their medications. We're going to make sure that their GFR is over 60. We're going to make sure they don't have malabsorption or low dietary calcium. We're going to rule out FGF, etc. If all of this happens, for example, hypercalciuria, and we do a thiazide challenge, if they remain normal, normal calcemic and normal PTH, then we know it's secondary hyperparathyroidism. It's not actually normal calcemic primary hyperparathyroidism. If they develop hypercalcemia, we can call it possibly classical hyperparathyroid. If they don't develop it, but PTH is still high, then we can call it normal calcemic hyperparathyroidism. Similarly, replace vitamin D if it's less than 30. If it remains elevated with PTH high and calcium normal, then maybe we can call this normal calcemic and guide them accordingly. The main takeaways of today, and hopefully I didn't go around in circles too much, the main takeaway should be that it's still not exactly clear what this entity is, and I think a lot of times we misdiagnose it, but the most important thing is not missing out on either the potential for end organ damage or rather the comorbid end organ damage that can occur, and having high suspicion for those and evaluating those accordingly, and then really, really working on getting rid of any secondary factors for PTH elevation and then repeating labs. And that can help us to really counsel patients on what to be worried about or not. Having a label of hyperparathyroidism is something that can be concerning to a lot of patients, especially if they go on the internet and look things up themselves. They can be really concerned about what that diagnosis means. So kind of counseling them accordingly and doing our part to eliminate secondary causes of PTH elevation and making this diagnosis appropriately. So with that, I will end and put up the CME code, and I'm happy to take any questions.
Hi, Malika. This is Swapna there.
Hello.
Hey, great talk. I know it was a very challenging topic. I had a couple questions. I don't know if the studies have any answers to those, but what was the mean time from diagnosis to the surgery that some of these patients underwent surgery for the normocalcemic hyperparathyroidism? And the second question would be, of the ones that failed, do we have any 24-hour urinary calcium data or idea about that, whether these were hypercalciuric, or whether they were hypocalciuric, which I think would be one of the common reasons to not diagnose a secondary hyperparathyroidism from decreased calcium intake, which I do see sometimes where they have very low calcium intake and their urine calcium's low and their parathyroid's high, parathyroid hormones high. So
Yeah, I
any
didn't.
input?
Sorry, I'm sorry. I didn't see anything about the time between diagnosis and surgery, so I can definitely look back and touch base with you again, circle around and let you know if I find that. As far as the urinary calcium excretion, they did not mention that, but I do think you raise a really good point, and that's why, I think at least in my own practice after preparing for this, I'm going to do a better job of asking patients about their calcium intake and trying to quantify it. Because I think that plays a big role in our diagnosis. And just like any hyperparathyroidism or PTH elevation, we're always looking to exclude FHH as well, if they're hypercalciuric and everything. So looking into that more, I think, is important in emphasizing adequate calcium intake. But I will try to see if I can find some more information for you to answer those questions.
Thank you.
Yeah.
Great talk. Thanks for taking my suggestion. I know this was sort of discussions that we commonly think about, but never comes out to light. So you did a great job putting all the challenging questions together. So I had a comment and a question. The comment is my experience with our otolaryngology colleagues here, especially Dr. Bumpus, whom I've had the most experience over the last 18 years. He seldom takes on patients with normocalcemic hyperpara. He's extremely reluctant for good reason with the data you show. The place when we refuse here, patients drive to Florida to Norman Parathyroid Center.
Oh gosh.
Get it done, which many of us have experienced with patients. And of course, they get it done, PTH goes down, within 3 months, promptly it's back up again. They have a placebo effect and say, oh, my brain fog is better and whatever, but then promptly a few months later, PTH goes back up. Or in the process, they develop hypocalcemia. So in at least at the VA, I can say we don't do so much of it. We deeply explore all the secondary classes. My question was, something I learned today was the calcium phosphate PTH index. Is there a lot of studies on that? Because I've seen the CAP ratio before, but I've never heard about the calcium phos PTH. I thought that was a very interesting number.
Not a lot. So it was, this PF index. So it was proposed by this group, by Dr. Guo and his colleagues. And I didn't see any other studies that used it, unlike the calcium phosphate ratio. And I've also never calculated it in a patient. But I found it interesting because unlike a lot of the other studies, I found that this researcher and his colleagues described the difference between normocalcemic and hypercalcemic patients that were all primary hyperparathyroid really well. So I felt more confident about the patients. They say 36 had normocalcemic. I felt like it was more clear that they did. So this index could be actually very helpful, but something I'll definitely use. And I'm not sure if those. I don't know if it's in MedCalc. Yeah, we might have to do it ourselves.
Yeah, many things in MedCalc.
Yeah.
That's a very new.
Yeah. There is someone out there that made something called EndoCalc. I have to look if it's on there. I haven't looked yet, but there's an EndoCalc too. So
Also, another thing I find interesting is NCCN's 2013 guidelines for asymptomatic.
Mhm.
And it's hard to say symptomatic versus, it's
Yeah.
a very tricky thing. We do this so often now. We get so many consults for elevated PTH, just like Dr. Levinson was telling earlier.
Yeah.
The urine calcium they use there is 400.
Yeah.
Whereas when we are doing an algorithmic calculation, we use it based on the female male,
Mhm.
300 versus 350 or whatever that number is.
Right.
So I always struggle with the difference in that. I never wait for them to go to that point with the asymptomatic because I feel like it's hard to say who's symptomatic or not.
Yeah.
So I feel like the last algorithm is much more helpful.
Much more. Yeah. So Dr. Krishnaswamy was mentioning that there's different cutoffs for urinary calcium in the International Consensus Workshop guidelines. They say 400 versus what we typically go by, which is gender specific. So she felt like this algorithm was a little more helpful. And she was mentioning that, there's some reticence or reluctance rather of surgeons to take on patients that are normocalcemic because it's almost like a initial improvement in the biochemical, status. Their PTH goes to normal and then it rises back again. So I don't know if I'm oversimplifying it, but I think if someone has elevated PTH, am I going to do surgery because there's elevated PTH, or am I going to look for any complications of it? Even patients that are hypercalcemic, primary hyperparathyroidism, if it's just mild, we kind of just monitor complications and go accordingly. So I don't know that there should be any rush.
The urine calcium, I know nephrology sometimes.
Mhm.
So my comment and question also pertains to hypercalciuria and urinary calcium. So you can see in the algorithm here where if the urinary calcium's high, they recommend this thyroid challenge test.
Mhm.
Joe Canary introduced in the 1960s
Mhm.
when PTH assays were very imprecise and insensitive to try to distinguish hypercalcemia due to hyperparathyroidism. So the idea here is that the thiazide is going to suppress PTH if it's secondary without causing hypercalcemia.
Mhm.
One
Yes.
guidelines that I read said you should continue the test for 6 months before you come to a conclusion whether it's primary hyperparathyroidism or whether it's idiopathic hypercalciuria with secondary hyperparathyroidism. So I wonder how long you would propose to do the thiazide diuretic challenge test and whether there was other information about data for that test that you found.
Yeah, I didn't find a good explanation on how they consider doing a thiazide test, but certainly can look into it. But I agree, we're supposed to see normal calcemia on separate lab values at least 3 to 6 months apart and measure the PTH in similar intervals. I don't think it would take 3 to 6 months for hypercalcemia to develop on a thiazide diuretic or for PTH to change that much on a thiazide diuretic, but I might consider monitoring them a little bit sooner. Maybe doing this for 3 months. I guess I would just I'm going based on what I would do clinically. So I didn't see any recommendation though on how long to continue it.
So how often is the test done? Were there data showing the utility of the test in a prospective way?
No, they were basically just saying if you put them on the thiazide and the next time you see them, they're hypercalcemic, then you got your answer. So yeah. And they call it a low dose thiazide test. So I would think 12.5 of HCTZ is kind of what they're recommending or something similar. So
That, like the reverse of this, when they're hypercalcemic and on a thiazide, the recommendation is just to stop it
it.
for 4 days
yeah,
and then repeat testing.
yeah.
So I don't know if that holds good the same way. So
So yeah, Dr. Krishnaswamy said if someone is hypercalcemic on a diuretic already, you're supposed to stop it 4 days, or on a thiazide diuretic, you're supposed to stop it for 4 days and retest. So maybe we can apply that in the reverse. Yeah, certainly I don't think it's going to take months for it to develop.
surgery. Normocalcemic and hyperparathyroid.
Oh gosh, Dr. Winters,
Yeah.
Dr. Moksha Gundam was remembering a patient you had that they saw at the VA that had hypercalciuria and nephrolithiasis. And the patient became hypercalcemic when they gave them a thiazide, so they did parathyroidectomy. And now as a result, the patient is just hypoparathyroid.
Oh,
He's hyperparathyroid. Oh, he has normal calcemic hyperparathyroidism now, after all that. Yeah.
Malika, I have one more question.
Yeah.
Beyond 5 feet.
Yeah.
That's related to when I was reviewing a manuscript a few years ago for one of the calcium journal. There was something about post-meal rise or post-meal suppression of PTH
Mhm.
and also diurnal variation. Did you see anything about that?
Definitely diurnal variation. And they talked about the timing of which we measure PTH, just like everything in our field, and better done in the morning for sure, because it follows the circadian type pattern. But I didn't see anything about the meal. No.
Okay.
Like aches and pain, depression,
Mhm.
and others.
Yeah.
Whole,
Brain fog.
It's the new Hashimoto's.
Correct.
Yeah.
And because one of my patients was insisting that he also had a slightly elevated aldosterone level,
Mhm.
that is due to hyperparathyroidism. And it is listed in that,
Yeah, there is an
and
association
there is also
Mm.
with
hyperparathyroidism,
hyperparathyroidism.
hyperaldo.
And he wanted his parathyroid surgery done because of that.
Oh, wow. Yeah, so I guess in summary, today we've learned that we still have a lot to research on what this means. Dr. Levinson, yeah.
Say, like that,
Mm-hmm.
because, I don't know how you could do any outcome study, because people are ill start out. You can't go out. And then, I'll tell you, I've always had a problem with measuring ionized calcium or corrected calcium. And I don't know how accurate.
Yeah, I mean,
Yeah.
I say that
The
now.
only way I can see when ionized calcium is you collect it like a blood gas, and then the blood gas instrument will do the calcium.
Mhm.
And then you get it pretty accurate.
You can feel good about it.
If you do it any other way, I just don't think.
There's a lot of variation. But
So
Yeah,
then,
and I think, corrected calcium, it's good.
It's
to
tried and
say,
true.
well, you're not below 4,
Yeah.
yeah.
you're 6, but you don't know what it is.
Yeah, so the recommendation in most is to do the corrected calcium rather than ionized. But the point they make, and whether it's the interassay variability like you mentioned, or the way that they check the ionized by ABG versus a VBG, like or a venous sample, is a lot of these patients have normal corrected calcium and a high ionized. So does that make them hypercalcemic? Yeah.
And I just don't know. So I like to
No,
say,
because-
it's not a test that I'd like to do.
Dr. Belzikian's things was 2013, correct?
Uh-huh.
And he has been saying that they'll come up with the guidelines, the corrective guidelines. Will come out shortly, and it's been 10 years later, and it's still not a clear guidelines.
Yeah, so we're
Guidelines, but
almost we're at 10 years and we don't have updated guidelines. I think people got tired of studying this, maybe. I don't know. There's no clear. Oh yeah. According to the workshop consensus from 10 years ago, you should send them for surgery, but according to surgical outcomes, you shouldn't send them for surgery. Yeah. All right. No questions. Oh, maybe questions. Wait, chat. There we go. Okay. That's from last week. No questions. All right. Well, thank you, everyone. Hope you have a good rest of the week.
Thank you.